and welcome to week 2 of DEN 200. So next we're going to start discussing caries detection. So dental caries, or tooth decay, is an infectious bacterial disease that has plagued human beings since, honestly, the beginning of time. Today, because of scientific advances and new technologies, dentistry is developing new strategies for managing dental caries. And these strategies usually are emphasizing prevention or earlier intervention rather than waiting until the issue becomes painful or super problematic. We're trying to catch these things earlier when they're smaller or even before the decay even starts through preventative measures. So first, bacterial infection. This is how decay forms. It's a bacterial infection. So there's two specific groups of bacteria that are found in the mouth that are responsible for dental caries. The first one is mutant streptococci, or MS, and then the second one is lactobacilli. So they are found in relatively large numbers in dental plaque. And the presence of lactobacilli in the mouth usually is resulting from a high sugar intake. So transmission of caries causing bacteria. Mutant streptococci are transmitted through saliva and most frequently from the mothers to the infant. So when a baby is born, a newborn baby, they do not have any of this bacteria in their mouth. It is passed down usually through the mother, either by kissing the baby or eating off of the same spoon or a fork as the baby, and then that baby then develops this bacteria in their mouth. When a mother has a high count of that bacteria, the baby also has a high count of the same bacteria. Women should be certain that their mouths are very healthy, so they're not passing any of these bacteria to their child. And when the number of caries causing bacteria in the mouth increases, the risk of dental caries then obviously increases as well. So plaque, or oral biofilm. Plaque is a colorless, soft, sticky coating that adheres to the teeth. Plaque remains attached to the tooth despite movement of the tongue, water rinsing, water spray, and less than thorough brushing. Formation of plaque on a tooth concentrates millions of microorganisms on that tooth. Now, we've already talked a little bit about the histological structure of enamel, but this is going to go into a little bit more about how decay forms into enamel. So again, enamel is the most highly mineralized tissue in the body, and it is stronger than bone. But enamel consists of microscopic crystals arranged in structural layers or rods known as prisms. The enamel crystals are surrounded by water, and the water and protein components in the tooth are important because this is how the acid travels into the tooth. The minerals travel out and the tooth structure dissolves. So when acid is present in the body, it kind of enters through those prisms, and in turn the minerals are kind of forced out of there and the tooth structure then dissolves. So that can really cause decay to appear rather quickly. So let's talk about the caries process. For caries to develop, 3 factors must be present at the same time. They all have to be present together. So number 1, a susceptible tooth. Number 2, a diet rich in fermentable carbohydrates, sugar, and then specific bacteria. So even if the number 1 and 2 are present, if that decay causing bacteria is not in that patient's mouth, they can't get decay. So if they were never exposed to it as a baby or as a child, their mom never passed it to them, their parents, grandparents, no one kissed them, ate off of the same spoon, and they don't have that bacteria present, they cannot develop tooth decay. So again, all 3 have to be present at one time, even if one or the other is not present. If a diet rich in fermentable carbs isn't present, you're not going to get tooth decay. So all of these have to be together at the same time for this to happen. Areas for development of caries. So pit and fissure caries occur primarily on the occlusal surfaces and the buccal and lingual grooves of posterior teeth, as well as the lingual pits in the maxillary incisors. So anywhere that there's a groove or a pit, bacteria is more likely to get trapped in there and is harder to clean out, frankly, because of it being kind of out of the reach of a normal toothbrush. You have to really get in there in order to clean out those grooves and pits. Smooth surface caries can occur on intact enamel other than pits and fissures, but is less likely. And then root surface caries occur on any surface of the root. The root is usually a little more, like not as smooth, a little more rough, so it can pick up plaque and bacteria pretty easily there. Secondary or recurrent caries occur on the tooth surrounding a restoration. So the tooth has already had cavities. You take the cavities out, place a filling, and then if it develops caries again, it's known as recurrent caries. So next, let's talk about the stages of caries development. So it usually takes some time, months to years, for a caries lesion to develop. It's not something that's going to happen overnight, especially if you're not brushing like once or twice. That's not going to cause a cavity. Over the span of months and years, yes, that will cause a cavity as that bacteria continues to build up. But the caries process is an ongoing process, usually characterized by alternating periods of demineralization and remineralization. So demineralization is the dissolution of the calcium and phosphate from the crystals inside of the enamel, whereas remineralization is the redisposition of calcium and phosphate in those previously demineralized areas. So demineralization, they're losing minerals. Remineralization, the body's putting those minerals back in there. It is possible for the process to occur without any loss of tooth structure. So if it is happening quickly enough where if it's getting demineralized and we're redepositing minerals back in, decay won't be able to start. It is important to note, though, that newly erupted teeth are especially vulnerable to acid attacks because they have fewer minerals present at the surface of the tooth. So, like newly erupted teeth are more likely to get cavities. That's why we place sealants to help prevent that, because those teeth are lacking the minerals needed to help prevent caries. So, as we continue here, an incipient lesion develops when caries begin to demineralize the enamel. An overt or frank lesion is characterized by cavitation, the development of a cavity or hole in the tooth. Rampant caries describes the time between the onset of the incipient lesion and the development of the cavity. It is rapid and there are multiple lesions throughout the mouth. So if you're seeing a patient who just has decay all over their mouth, we call that rampant caries. Now, secondary or recurrent caries, we talked about this a little bit a few slides back, but it is going to form in the spaces between the teeth and margins of a restoration. So the patient already had a restoration, a filling done, and now new decay is forming around the edges of where the tooth is meeting that filling at. Not easily seen and can be difficult to diagnose because of that. Sometimes x-rays will show it. That's usually how a patient is finding out that they have recurrent decay. So root decay forms obviously on the root of the teeth, but gingival recession typically needs to be present for this decay to form. If the gingiva is attached, especially to the roots, bacteria isn't going to be able to get in there to cause root decay. When that gingiva, like if someone has periodontal disease and the gum tissues are receding and the bone is receding there, the roots are more likely to start getting decay there. So having gum tissues, healthy gum tissues, is super important to prevent root caries. But the older population, who often has a lot of recession going on, are more likely to start developing these root caries. Older population also generally is taking medication, which can reduce saliva flow. So different medications, even like cancer medications, some heart medications, can reduce or even almost completely stop the flow of saliva, and people develop dry mouth. So dry mouth can lead to higher risk of cavities because saliva is what neutralizes those acids that help prevent decay. So by not having any saliva, nothing is there to neutralize those acids, and then decay starts to form very rampantly throughout the mouth. So things like biotin products, where it's helping to almost like act like saliva, to rinse away these bacteria, can be super important for the elderly population to prevent root caries. Carious lesions form more quickly on root surfaces than it does on the crown portions because the cementum on the root surfaces is a lot softer than the enamel and dentin. So once this root caries process starts, it often gets pretty bad pretty quickly. Like coronal caries, the root caries have periods of demineralization and remineralization. Early childhood caries, also known as ECC. Many children live with constant pain of decayed teeth and swollen gums. A lot of it revolves around having milks and juices in bottles in their cribs at night, baby bottle rot. In some states, ECC affects 1/3 of preschool children, like 1/3. That is a pretty high number. That's kind of alarming that it affects that many children. Tooth decay is the single most prevalent disease of childhood. So it's kind of everywhere, especially with all these sugary drinks, juices, even milk has sugar in it, that if children are going to bed and not brushing their teeth after drinking, even waking up in the night and getting it and just falling back to sleep, it's going to sit on the teeth and it's going to start to cause issues there. Early childhood caries can be prevented with appropriate education of the parents, so telling them not to allow their children to have a bottle in the crib, to not sleep with the bottle at nighttime, to brush their teeth, or even use like a wet gauze or wet washcloth to brush off the gums and teeth at nighttime after ingesting sugary things. And of course, oral health care. So getting them into the dentist as soon as their first tooth erupts as a child, to start the oral health care process, making sure they have fluoride, are brushing their teeth properly, things like that. Risk factors for ECC. So ECC is common among families of lower socioeconomic status. Typically, these people don't have the education needed. They think like their parents offered them a bottle at nighttime, so they're going to do the same. They may not have dental insurance for themselves or their children. So unfortunately, those who are poorer are more affected by ECC. The rate of untreated dental disease among low-income children aged 2 to 5 is almost 5 times higher than that seen in higher income families. ECC is more common among particular ethnic groups, in families who have limited access to dental care, in areas where water fluoridation is lacking. So if the township has gotten rid of the community fluoride in the community water, this greatly affects children. It's going to cause a lot of issues that may not be seen for a few years even, but it will cause issues. So in those cases, it's extremely important to have dental care and to be getting fluoride topically, because they're not ingesting it systemically. So how do children get ECC? ECC is a transmissible disease. It can be, like we talked about before, like it can be transferred through using utensils or kissing, things like that. Bacteria in the parent's or caregiver's mouth are passed to the child then, and it is important for parents to keep their own teeth healthy in order to keep their children's teeth healthy. Baby bottle decay is another term for ECC. And saliva is just so important. So physical protection involves a cleansing effect. The saliva is reducing the bacteria, reducing the acid, which is leading to dental decay. Thick or viscous saliva is less effective than a more watery saliva in clearing carbohydrates. Chemical protection contains calcium, phosphate, and fluoride, and chemical protection includes buffers, bicarbonate, phosphate, and small proteins that neutralize the acids after we ingest fermented carbohydrates. Antibacterial substances in saliva work against the bacteria. And then if salivary function is reduced for any reason, the teeth are then at increased risk for decay. So like we previously mentioned, if a patient is on medications that reduce the flow of saliva, it is going to cause eventually issues with decay, because that saliva is what's neutralizing the acids, and without it, decay is going to start forming. Caries diagnosis. So the following methods are used to detect dental caries, and each has specific limitations. So the Dental Explorer, obviously we're just using that to manually check for stickiness in a tooth, and if that stickiness is there, or like the softness inside of a tooth, we know that there's a cavity present. Radiographs are huge, as you can see in the picture here. Obviously, we probably would have clinically seen this area of decay on a patient, but sometimes you can see areas of decay, and the radiograph is the only way that we're able to see them, especially if they're interproximal. Visual appearance, so just by looking in the patient's mouth and being able to see decay, indicator dyes, and laser caries detection. So things like the diagnet dent that is able to detect areas of decay. So caries detection devices. There are several types of devices that have been developed that can provide a higher level of discrimination in the diagnosis of dental caries. Some detect bacterial byproducts and quantify sound signals to aid in caries detection. Some detect differences in tooth structures and display information on the screen. And then others, like Overjet seen in this picture here, have software that analyzes density changes on digital radiographs and outlines potential lesions. So essentially the patient's x-rays get imported into the Overjet system, and then Overjet uses like AI algorithms and things to be able to mark areas of concern like decay. It can mark fillings. Seen in the picture, you can see like green lines that are marking bone recession, which can help with periodontal disease. So kind of a cool program that's starting to become more popular. We also have laser caries detectors, which are used to diagnose caries and reveal bacterial activity under the enamel surface. The caries tooth structure is less dense and gives us a higher reading than non-caries tooth structure. Usually at my office, it was a number 32 and above would mean that, okay, we probably need to do a filling here due to decay being present. You also have to take in consideration, though, that if the patient has prior fillings done or even sealants, that can throw off the number reading for this. CAMBRA. So CAMBRA is caries management by risk assessment. It is an evidence-based strategy for preventative and reparative care for early dental caries that can be used in any dental office. So a dental health professional, aka the dentist or us or the hygienist, assesses an individual's risk factors and protective factors, then determines the level of risk for the caries. So they can be all the way from low risk to a very extreme risk. An individual preventative plan is then developed based on the determined level of risk. Methods of carie intervention. So fluoride is always great at caries intervention. Variety of types available to strengthen the tooth against solubility to acid. There's antibacterial rinses, different mouth rinses, chlorhexidine, even like Listerine things. Decreased fermentable carbohydrates, so eating less sugars and reducing the risk of ingestion of those. And increased salivary flow. So chewing sugarless gum helps improve how much saliva you have. So especially things like xylitol. Xylitol is a non-sugar sweetener that is in a lot of chewing gum that is proven to help increase the flow of saliva, which therefore reduces the risk of cavities. So you may see things saying that xylitol helps reduce cavities. And there's caries risk assessment tools. So they are helping to identify any factors that contribute to an increased risk for dental caries. It's usually a saliva test that the patient spits into a tube, and then that's sent off to a lab, and then the lab is able to determine if their saliva is capable of essentially neutralizing the acids in the patient's mouth. So high bacterial counts, again, for those bacteria that cause decay, that's also detected in there. Higher counts of the bacteria indicate a higher risk of caries, and lower counts indicate a lower risk. And then patients in whom a caries risk test is indicated. I mean, we're obviously not testing every single person that comes through the door, but here are some times that we may want to test people. New patients that have a lot of carious activity. Pregnant patients. A lot of times during pregnancy, hormonal changes and saliva changes, medications, things like that can cause more of an increased risk of caries. Patients experiencing a sudden increase in the incidence of caries, individuals taking medications that may affect the flow of saliva, and xerostomach patients. So demineralization and remineralization, we've kind of talked about this a little bit already, but demineralization is the removal of minerals from the enamel in the form of mineral ions, and it happens when acids found in bacteria and sugar attack your enamel. And then we have remineralization, the process of supplying calcium and phosphate ions from a source outside the tooth to induce ion deposition into demineralized enamel to achieve net mineral gain. So we are putting all those minerals back into those demineralized spots and getting that area back. So fluoride can do this, saliva can do this, those xylitol sugarless chewing gums or mints can do this. So, basic cavity preparations. When preparing a tooth for a permanent restoration, the dentist needs to have basic knowledge, not a basic, extreme knowledge about the direction of the enamel nut rods, the thickness of the enamel of the tooth they're prepping, the body of the dentin, size and position of the pulp, the crown of the tooth as it relates to the gingival tissues. Terminology. So an understanding of the terminology of a cavity prep will help you to know which dental instruments, dental accessories, dental materials, anything that you need to have ready at all appropriate times throughout the procedure. So cavity preparation is the process of removing diseased tooth structure while leaving healthy tooth structure for the tooth to maintain a restoration. So we're getting rid of all of the decay and diseased areas to be able to place a filling that is going to then allow the tooth to function as normal. There are basic components to all cavity classes. So each tooth has walls for their cavity preps, which is a vertical or horizontal surface within the cavity preparation named for the surfaces towards which it faces, or for a structure it approximates. So as you can see in the picture to the side, there are some external walls, the distal, the facial, the lingual, the gingival wall. And then there's also some internal walls, such as the pulpal wall or the axial wall. So then we have cavosurface. They are cavosurface margins. They are the uncut tooth structure adjacent to the cavity preparation. And then we also have line angles, which are lines formed along the junction of two walls or of one wall and the cavosurface margin. They are named according to the walls and surfaces involved. So next we have point angles. So a point is formed by the junction of three walls within a cavity prep. They are named according to the three walls involved. Retentive features include grooves, pits, or prepared areas in the dentin along the line angles or point angles of the preparation to enhance the mechanical retention of the restorative materials and named according to their location. So initial cavity preparation. Outline form is the design and initial depth of sound tooth structure. Resistance form is the primary shape and placement of cavity walls. Retention form is to resist displacement or removal. Convenience form is accessibility in preparing and restoring the tooth. Then final cavity preparation includes removing any enamel, diseased dentin, or old restorative material, or a combination of all three. It also includes inserting additional resistance and retention notches, grooves, and coves, anything that's going to help that restoration stay in place for a long time. And then it also includes placing protective dental materials such as linings, bases, any desensitizing materials, or bonding agents. So next we're going to be discussing caries classifications. So dental caries, which is also known as decay, can occur anywhere on the surface of the clinical crown of a tooth. Dental plaque, which is essentially bacteria, and sugars from refined carbs form acids that then begin to destroy tooth structure. There are different kinds of caries. There can be pit and fissure caries or also smooth surface caries. So one way to classify caries is, again, based on these two different ways, pits and fissures or smooth. So pits and fissure caries include enamel defects that result from the incomplete fusion of enamel in the developmental stage. So when you're looking at the occlusal surface of a posterior molar, we'll say, and all of those grooves are in there, similar to where we'd place sealants at, that is a really prime area for people to get cavities in because that enamel is not fully fused together. It almost creates a little crater there and bacteria gets stuck in and it's very hard to brush it out. So a very common place for caries to develop is in those pits and fissures. And then the smooth surfaces is kind of, it can be on the outside of the tooth, like along the buccal or the lingual side. It's not anything that has to do with incomplete enamel. It's just because the tooth wasn't essentially kept clean and plaque and bacteria build up there over time and just start to eat away at the enamel. So G.B. Black developed a caries classification system a long time ago that is still used today. He is one of the founders of modern dentistry in the U.S. and is actually known as the father of operative dentistry. So it uses Roman numerals to classify the types of caries. So there's class 1 through 5, and more recently there is a 6th classification as well that's been developed. So as you can see in the picture here, all of the classes that we typically use. So class 1 restorations are carious lesions that are located in the pits and fissures of the occlusal, facial, and lingual surfaces of the posterior teeth and on lingual surfaces of anterior teeth. So class 1 is going to be on the biting surface. More than one class 1 lesion may be present on the same tooth, especially for like molars, we'll say. There could be 2 separate class 1 lesions on the mesial and the distal. So if the lesions increase in size, the ridge is then destroyed as they meet kind of in the middle, and then it becomes just one large class 1 lesion. The following surfaces are involved. So occlusal pits and fissures of premolars and molars, buccal pits and fissures of mandibular molars, lingual pits and fissures of the maxillary molars, and lingual pits of maxillary incisors, which is most frequently in the pit near the cingulum. Class 2 restoration. So a class 2 is the extension of a class 1 into the interproximal surfaces of those posterior teeth. So it can start as a class 1, or it can just totally be solely interproximal and not really involving the occlusal at all. When they are small, they may only be detected with a radiograph because we typically can't see interproximally, especially if there's another tooth adjacent to it. So a lot of the times we're finding these cavities through radiographs. And the following surfaces are involved. So 2 surface restoration of posterior teeth, 3 surface restoration of posterior teeth, multi-surface, so 4 surface or more restorations of posterior teeth. Class 3 restorations, they affect the interproximal surface of incisors and canines, so anterior teeth, but they do not involve the incisal edge, no biting surface. They begin on the smooth surface area just gingival to the contact area. And these lesions must be prepared from the facial or lingual sides, and dentists usually select the best approach that preserves the tooth structure and aesthetics the best. So ideally with these, if you can access them from the lingual, that's typically preferred because then it's not going to affect aesthetics as much from the front. Class 4 restorations. So these are located on the proximal surface of anterior teeth and involve the incisal edge. So very similar to class 3s, but now we're getting that biting surface incisal edge involved. So can be the result of a class 3 that has progressed in size or by the result of trauma. So you'll see this a lot in kids who are playing sports and may chip a tooth that way, or fall off their bike, or jumping on the trampoline. Trauma that's involved, or even people who bite their fingernails or are biting into something hard and their tooth just breaks. So again, very similar to class 3s, but now we're getting that biting edge involved. And then we have class 5 restorations. So these are located on the gingival third of the facial and lingual surfaces of anterior and posterior teeth. They are classified as a smooth surface restoration. And then these lesions can occur at the gingival third of the facial or lingual surfaces of any tooth. They can also occur at the root of the tooth near the CEJ. And then this newer classification, class 6 restorations, involve the cusp tips of posterior teeth or only in the incisal edge of anterior teeth. These are not very common because those are kind of awkward places to get caries at, which is why it's kind of a newer classification. Like, it's not seen very often. I've maybe seen it on 1 or 2 patients in my whole career, and sometimes it's just from like from grinding, and then decay gets in there. Sometimes I'm just honestly not sure how it occurs because it's in just such a unique location. So then we have minimally invasive restorations. So Sometimes, if decay is present just solely in the interproximal area and it's not involving the occlusal much at all, obviously we still have to access that interproximal area and go through the occlusal portion, but sometimes we don't need to take that whole occlusal out if the decay is not there. So this is a very conservative preparation, and oftentimes it's called a tunnel or a slot prep. So it's designed to minimize the amount of tooth structure that needs to be removed in order to restore the tooth. So as you can see in these pictures, A represents a typical class 2 preparation where, yes, we're getting that interproximal decay out, but we're also removing a good portion of that occlusal as well, just for retention purposes. And then letter B is showing you what a slot preparation is. So it involves a lot less of the occlusal surface, but still enough that you can access the area interproximally to get your instruments down and be able to pack and condense the composite into it. And then letter C is showing a tunnel preparation where it's kind of going at an angle to access the decay, but still it's very conservative in regards to preserving tooth structure. So some doctors love doing these, some refuse to do these. I have noticed that more often it is slot preparations that are failing compared to like normal restorations. I'm not sure if it's because of the lack of retention with a slot preparation, or what it is, but I've seen a few slot preparations fail, just for no reason at all. So just something to keep in mind. But again, some doctors love doing these, so obviously it works for them very well. But you may just see these depending on what doctor you work for. Just something to keep in mind. It's done basically the same as a normal restoration. You just have to make sure that you have instruments small enough that you can still condense appropriately without as wide of an opening as with a traditional preparation. So let's talk a little bit more about these tunnel preparations. They were developed to avoid the removal of the marginal ridge when placing a filling. They're not very popular. I've honestly have never placed a tunnel preparation filling. Like I mentioned, I have placed slot preparation fillings quite a few times. Never have seen or come across a tunnel preparation. The textbook said they're not usually taught in academic settings for the dentist, and are seldom used. So why are we talking about them? Not sure. But in case you ever come across one, it'll be helpful to recognize and understand exactly how to place these fillings. So the steps to placing a filling if there is a tunnel prep. We want to inspect the preparation to visualize the extent of the margins, especially interproximal. We need to see exactly where this tunnel prep is starting and where it's ending in the tooth. Next, we want to place a matrix band and ensure that it's going to reach that interproximal portion of the tunnel. We need to wedge the matrix band to ensure adequate adaptation. We need to place the restoration in very small increments and making sure to condense a lot so there's no voids present. Extend the curing time to assure complete curing. With that curve, it can sometimes be hard to get proper curing. Remove flash once the matrix band is removed, and then finishing can also be hard because of the location of the exit of the tunnel prep. So sometimes you may need to use like a finishing strip to get down in there. Now, slot preparation is going to be a lot more common. Again, developed to minimize the amount of natural tooth that is needed to be removed. They're usually reserved for older patients that are past the cavity-prone years, and they frequently do not have an occlusal step. It's usually just one fluid box straight to the cavity. The steps, though, are the exact same as a tunnel preps placement. So again, we're going to inspect the preparation to ensure that we know where it's going, the extent of the margins. We're going to place a matrix band, wedge it, place the restoration in small increments, extend the curing time, remove flash. Finishing can be a little difficult sometimes. Essentially, it's just like placing, though, a class 2 that involves the occlusal surface. It's not much different, just a smaller area and less work you have to do. Just make sure you're bonding really good because that occlusal surface isn't involved as much, the retention can be a little off, so making sure you bond appropriately to hold that in there is really important. So next we're going to be discussing moisture control. So what are the advantages of a dry operating field? A dry operating field is essentially everything when placing a filling or doing any kind of restorative work. We need the teeth to be dry at all times, not contaminated with blood or saliva, so that everything can appropriately bond and the patient doesn't have any future issues. So advantages include better visibility to the area being restored, clean and dry cavity walls, development of full properties in the materials being used, which may be inhibited if moisture is present. It also allows for easier access to cavity walls in the placement of liners, bases, and restorative materials. And isolation techniques should, 1, isolate the clinical crowns of the teeth. They should retract and control the soft tissues, including the lips, cheek, and tongue, and offer limited gingival retraction as well. They should also prevent moisture contamination of the teeth, provide optimum visibility of the operative site, protect the patient against aspiration, not interfere with the operator's visual or mechanical access to the operating site, be comfortable for the patient, and be easily and rapidly accomplished. So we don't want anything too difficult that's going to make our jobs harder. We want it to be fairly quick and simple. So oral evacuation systems are used to remove excess fluid and debris from the mouth. I'm sure we're all familiar with these, just a quick overview. So saliva ejectors, some people call them Mr. Thirsty. They are small, straw-shaped, flexible, and they also bend a little bit. So they can be used during less invasive procedures like prophy, sealants, ortho procedures, and to remove saliva from under dental dams. They're also good for like rinses in the mouth. The main focus though is to remove liquids from the mouth, not strong enough to remove debris. So if you are, if the doctor's prepping a tooth and there's amalgam pieces going everywhere, you probably don't want to use the saliva ejector. The HVE is your best option. So the HVE, or high volume evacuator, is a high volume of air that is moved into the vacuum hose at a low pressure, which creates a very strong suction. It is used to remove saliva, blood, water, and various debris, and you can also use it to retract tongues, cheeks, lips, whatever you need from the operating field as well. I like to joke with patients that try to close down on the HVE that it could rip their tonsils out because it is that strong. I don't think it would actually rip them out, but it sometimes feels like that when it's latched on, so just be careful that you're not sucking up too much stuff with the HVE. So HVE tips, there are various types of tips available. Operative suction tips are a bit larger. They're used during most procedures like fillings, crowns, and bridges, and they can either come bent or straight. And then we have surgical suction tips. They have a smaller, very thin opening, and they're used during special procedures such as extractions, root canals, or oral surgery. They're going to be less likely to suction up any blood clots that are forming that we need there in the socket during surgeries. So for most procedures, we're going to be seeing those bigger operative suction tips. So next, we're going to discuss how to properly grasp and position the evacuators. So you want to use a thumb to nose grasp, which is, there we go, holding it like this, or a pen grasp, where we're almost holding it similar to a pen position, just like in that picture there, actually. When assisting a right-handed operator, the assistant grasps the evacuator with their right hand and vice versa. Left-handed, the assistant grasps with their left hand. The hand that is not holding the suction holds the air water syringe or is transferring instruments. So you should always have something going on with both your hands. Different tips though. Place the evacuator before the dentist positions the handpiece and mirror. By doing it before, you're able to help retract a little bit to get that mirror in, and you're not going to block them once they get started. You want to position the suction tip on the surface of the operative tooth closest to you, or one tooth distal. So you want to be really close to where the dentist is working so you can get all the water that's coming off and any debris that may come off. You want to position the bevel of the suction tip so that it is parallel to the tooth surface. And then for anterior teeth, keep the edge of the suction tip even with or slightly beyond the incisal edge. This video can be found in the resources folder for this week. I'm not going to play the whole thing on the lecture, but be sure to check it out in the materials and resources section. So rinsing the oral cavity. Rinsing helps to maintain a clear operating field and helps keep patients comfortable. They don't want to be sitting there with a mouth full of debris the whole time. They want to feel like there's nothing going on in their mouth and it's clean and there's no bad taste and everything's great. So, two types of rinsing. There's limited area rinsing, where we're just kind of rinsing off the tooth or a little bit of an area that we're working on. This should be accomplished quickly and efficiently, causing no delay in procedure. So, I'll usually do this if the doctor is taking a little break to maybe change their burr or change their gloves, something like that. They're not there working on the patient. I'll do a quick rinse of the area to make sure that they can see, or different parts in the procedure, like if they're drilling out the existing amalgam filling and there's just amalgam debris everywhere, I'll just keep giving little rinses there to help keep the area clean. There's also full mouth rinsing though. This is when the patient's entire mouth needs refreshing. It may be done after a long restorative appointment, after cleaning, or before the patient is leaving the office. So the saliva ejector can be used, and you just kind of go around the entire mouth and you get all of the yuckiness out of there for them. So next we're going to discuss air water syringes. With an air water syringe, there's two buttons at the top. One is going to deliver air, the other button is going to deliver water, and when you press them both at the same time, it is going to deliver a more aerosol version of a water stream, so almost like a puff of air and water at the same time. So guidelines for using an air water syringe. You want to direct the syringe tip towards the tooth being treated, obviously, so you're not getting your doctor in the face or yourself in the face. Point it directly where you want it to go. You want to keep a close distance between the area that you are spraying and the syringe tip. So being too far away from the working site can create a lot of aerosol and splatter and unwanted debris going into the air. So even keep your HVE or saliva ejector nearby as well. Use the air on the mouth mirror continuously when indirect vision is involved. So if the doctor is viewing a tooth on the top and also using the handpiece with lots of water, you want to be drying off that mirror so that the dentist can see properly. And then when you hear the handpiece stop, it's a good time to rinse and dry the site. And then when completing a limited area or full mouth rinse, move the tip throughout the mouth while spraying the area. Isolating teeth. So teeth must be kept isolated for optimum results. Losing isolation could mean that saliva, blood, and bacteria has entered the tooth during treatment and the work may need to be replaced. That's not good. So different types of isolation. There's cotton roll isolation, as you can see in the picture here, just keeping a little bit of retraction with the lip area there and keeping the tongue out of the way. But it's also soaking up any unwanted saliva. There's also dry angle isolation and dental dam isolation. So cotton roll isolation, one of the oldest methods. It's recommended during shorter procedures. They should be placed adjacent to the parotid and sublingual gland ducts to absorb saliva flow. Some advantages: they're easy to apply, no additional equipment is required, and they are available in many different sizes. You can cut them to size, you can kind of pull them outward to enlarge them. They're very flexible. Disadvantages include that they do not provide complete isolation. It's very easy for saliva to even oversaturate the cotton roll, and then you just have like a whole trapped area of saliva that can easily be squished into your prep site. It doesn't protect the patient from aspiration, so they could swallow the cotton rolls. Dry cotton rolls may stick to the gum tissues and cause irritation, so oftentimes you may need to spray a little water on them before you remove them if they are still dry. They do need replaced frequently throughout a procedure because of oversaturation, and they provide limited retraction. A little bit, but not a whole lot. Dry angle isolation, you can see in the picture here, that's a dry angle. So they are triangular absorbent pads. They help isolate posterior areas in the maxillary and mandibular arches by blocking the flow of saliva and protect the tissues in the area. We often call these cheek patches. They do a great job of protecting the cheeks when you're working on a back tooth, to prevent the cheeks from getting kind of tangled into the burr of the handpiece. You do want to replace pads if they become soaked before the procedure has been completed. And then to remove them, if they are dry, you may have to use a little bit of water from the air water syringe to wet the pad thoroughly before you separate it from the. So with dental dams, they do meet most of the criteria for ideal isolation of teeth, even though they're kind of a pain to use. They are thin, stretchable, they become a barrier if they are appropriately applied to the selected teeth. So when a dam is in place, only the selected teeth are visible through the dam. The rest of the teeth are kind of hidden under that dam barrier. So indications for use of a dental dam. They serve as an important infection control barrier in the preparation of teeth. It safeguards patients against contact with debris, dental materials, and other liquids during treatment. It protects the patient from accidentally swallowing any debris, provides moisture control, retracts lips, tongues, and gingiva from the field of operation, and provides better visibility due to contrasting colors of dental dam and tooth. So as you can see in the picture above, because it's hiding all those other teeth, that green really serves as a great contrast against the tooth, so you can see a little bit better. Now, disadvantages of dental dam use. It takes a lot of time to set up, and patients often hate them because they may feel claustrophobic with them. That something's taking up so much of their mouth, they may feel like they're unable to breathe or having more difficulty breathing. So a lot of times, these aren't used every day for procedures, maybe just for root canals, but some dentists do like using these a lot for restorative procedures because they are just so dang useful, even if they take a little bit of extra time to use. Armamentarium for dental dams. So what all do we need? We need some waxed dental floss. We're going to use this as a ligature to tie to the clamps to prevent the patient from accidentally swallowing them. We need the rubber dam itself. We need a rubber dam template and ballpoint pen. This is optional, but it'll just be helpful to determine exactly where we need to make a hole for the teeth we're working on. A rubber dam punch to punch that hole. Lubrication for patients' lips is always useful, just so they're not getting chapped over dry lips. We need a rubber dental dam napkin or a 2x2 gauze. We need the rubber dental dam frame or holder. We need assorted rubber dam clamps and rubber dam forceps to attach to the clamps to insert them. We need a burnisher or rubber dam inverter. I often use a gold plastic flat instrument just to help get the sides of the rubber dam over the wings of the clamps, and then small scissors are helpful as well. So let's discuss dental dam clamps. There are a few different types of clamps. They are used on different teeth. So all of the clamps have the following, no matter which teeth they are for. They have the jaw part, which is the part of the clamp that is expanded to fit over a tooth. They have the forceps holes, which are the two little holes you can see in the pictures where the forceps attach into them to be able to open them wider in order to fit over teeth. They have points, or the parts of the jaws that contact the tooth when the clamp is properly placed on the tooth, and then the bow, which is that arched portion, and usually this is where we're tying floss to as a ligature to ensure the patient isn't swallowing it. You can see in the picture here, the molar and premolar ones look very similar, but look kind of towards that center jaw portion, where the molar one is a little bit wider. Obviously, molars are wider than premolars, so that opening has to be a little bigger to fit over a molar, whereas the premolar one's a little bit smaller. And then the anterior one we call a butterfly clamp, because it almost has two bows going on either side. So those are always easy to pick out compared to the molars and premolars. Then we have the dental dam forceps. So this is what's going into the little holes of the clamp in order to widen it a little to get over the tooth. The bow of the clamp should be positioned distally if possible. If it's the very last tooth in the arch, it may be hard to position distally, but ideally that kind of rounded bow portion is always to the back of the mouth. And then when the forceps handles are squeezed together, the locking ring slides towards the handle, and the jaws of the clamp will remain open, maintaining the clamp and the forceps. So if you're trying to then close the clamp again, you have to slide that little bar back up to the top in order to be able to close it. There are pre-punched dental dams. I call these almost like auto dental dams, where you don't need a frame or a punch or anything really. You just need the forceps, the clamps, and then this pre-punched dam, and then you have everything you need. Many offices use this. It saves time, makes it easier for the assistant to place the dental dam for the dentist. So these are an option as well. So placement of the dental dam. First, you want to explain the procedure to the patient, let them know what's going on, because it can be a little shocking if they've never had one placed before, and they may feel, again, very claustrophobic with it. Then we're going to examine the patient's mouth to see where the dental dam is to be placed at. We want to pinpoint that tooth and also floss that area to remove any plaque or debris that may be there. Next, we're going to select the proper rubber dam clamp. So if it's a molar, we need to get the molar one, premolar, or is it an anterior where we need to get the butterfly clamp. To minimize accidental aspiration, we're going to tie that floss ligature to the bow of the clamp. We're going to use the forceps to pick up the clamp. We're going to position the clamp over the tooth, confirm the comfort of the patient, and then use a template to mark the holes that are to be punched. Then we're going to punch the rubber dam holes, lubricate the patient's lips with some petroleum jelly or chapstick something. We're going to place the rubber dam. We're going to use a blunt-shaped instrument. Like I said, I use that gold flat instrument to release the rubber dam from each wing of the clamp. And then we're going to expose the remaining teeth, place the frame with the concave side of the base towards the patient, stabilize the dam by ligating the tooth farthest from the clamped tooth. So this seems like a lot of information, but we're going to go over this in lab on Saturday, so don't freak out yet. So then removing it is pretty easy as well. So we're going to first protect the patient's eyes in case anything flies off of there like a clamp. We're going to remove any pieces of rubber dam or floss used for ligation with scissors and pull the ends through the embrasures. We're going to grasp the dam and pull it in a facial direction to enlarge the hole and allow access for the scissors. You then want to cut each interdental septum with scissors. And we're going to cut the rubber between each of the teeth, use the forceps to remove the clamp and simultaneously remove the dam with the frame. Remove the rubber dam napkin if it was used. Caution the patient not to bite down on occlusal or incisal restorations, especially if the occlusion is not correct yet. We're going to check that all the rubber dam material is removed. Use dental floss or an explorer to remove extra pieces that may still be in there. And then be prepared to offer the patient a paper towel or a mouth rinse, something to wash out with at this time. Before that occlusion is evaluated. So again, this video I'm not going to play for the lecture, but it is in your materials and resources section, how to place a rubber dam. So be sure to review that before lab. And then this week we're also going to discuss briefly temporary crowns and bridges so that you can complete your crown and bridge competency in lab classes. So making a temporary crown. Once the tooth is shaped for the crown, temporary material will be added to the tooth in the overimpression and placed back into the patient's mouth to harden. Typically it takes 1 or 2 minutes for the material to harden, and you can squeeze a little of the material on your tray. That way you can test it throughout and see if it's set yet. Different shades are available, so make sure you're picking the right shade for your patient. So next, let's discuss some issues that you may come across when making a temporary crown or bridge. If you come across any occlusal errors or voids in the temporary, you can trim away any tags, and then you can either put a little extra temporary material in there, or sometimes I even use a little bonding on the temporary only, not the patient's tooth, and then just add a little bit of flowable composite and cure that to kind of seal that void or air bubble. If your temporary is locking onto the restoration and keeps breaking when you try to take it off, there may be an undercut present in that area, and the dentist may need to adjust their prep a little bit more in order to get a temporary off that isn't going to break there. Any marginal discrepancies, like in the photo there, you may need to reline it with more material and then set it back onto the prep tooth again to allow it to set. There is a video for making a temporary crown. Again, please view the video in the materials and resources section of this week. Now, temporizing a bridge is very similar to temporizing a crown, but there are 2 different instances with bridges that can kind of change the way that you make the temporary. So if the pontic tooth is already missing, it's been extracted already, you may want to put some wax or expired composite to make a mock tooth before the overimpression is taken. And with this type of bridge, the final impression is taken that same day because the tooth is already missing, the gums are already healed in that area. So you can just go ahead with making the final bridge. Now, if the tooth is still there and needs extracted, it's typically extracted that day of the appointment. So you still want to take an overimpression at the beginning of the appointment. If the tooth is still there and it's whole, just take the overimpression. If it's chipped or broken, anything like that, you may, again, want to use wax or composite to build the tooth back up to look normal before you take the overimpression. That'll just save you some time. The doctor will then prep the abutment for the bridge, polish the broken pontic tooth to the gum line usually, and then you'll make the temporary. It'll be all done, and then after that, the doctor can extract the broken tooth. It's already at the gum line, so it'll be easier to get like that root portion out. And then after the blood clots for a few minutes, you can go ahead and cement the temporary bridge in. Now, the patient will need to heal before a final impression is taken in this case. They'll usually need 6 to 8 weeks for that gum tissue to heal, and then they can come back in for that final impression, where they'll need to take the final impression and leave again in a temporary until the lab finishes the final. And one more time, this video you can watch in the materials and resources folder for this week. If you have any questions or concerns about this week's lecture or PowerPoint, please let me know. Thanks.